Okay. Okay, apologies. We'll start again. Today I wanted to talk about polio and acute flaccid paralysis. And as I said, we have talked about acute flaccid paralysis, AFP, before in terms of neurological assessment of a child and a hypotonic infant. But I really wanted to talk a bit about polio today and to understand all the different technical aspects of polio. It's quite complex in the modern era. And I think um, polio and um, acute flaccid paralysis used to be relatively simple in the last century, if you like, 25 years ago. But now I think in the last 10 years especially, it's become a bit more of a complex issue and it's one that we need to address. So first of all, I wanted to talk just for those who aren't familiar with acute flaccid paralysis and what it means. It's very we all become familiar with that because even if we don't see a case of polio, we need to be reporting cases of acute flaccid paralysis. And the definition is very broad. It's not, is the classical definition of polio, and then there's a broader definition of the type of illness that the polio enterovirus might cause. But it's a sudden onset of weakness or paralysis, usually sudden onset. It may affect arm or leg, and it's associated with a loss of muscle tone, obviously not caused by injury. That some of the manifestations of that involve facial weakness or facial drooping, difficulty moving the eyes or drooping eyelids. Sometimes children have speech or swallowing difficulties. They may have slurred speech or difficult swallowing, or they might have airway obstruction, drooling of saliva associated with hypotonia of one or more limbs. Some children with acute flaccid paralysis, especially older children, will have some sensory changes and they may have tingling or numbness in the limbs indicating sensory nerve involvement. Now, that's not a feature of polio, but it is a feature of some forms of acute flaccid paralysis, particularly Guillain-Barre syndrome. I'll explain the differences. And some children will have progression to respiratory failure, either because of respiratory muscle fatigue or hyperventilation, sometimes from bulbar dysfunction and an inability to maintain their airway. And some children with certain types of acute flaccid paralysis will have disruption to autonomic function, especially heart rate and blood pressure. They may have unusual tachycardia or bradycardia, particularly, or hypotension as sort of autonomic neuropathy. And again, that is a feature not so much of polio, but some other forms of acute flaccid paralysis. There are, I haven't ordered these in um, in numerical priority because they differ from different regions, different locations, different times in terms of what's the common cause of acute flaccid paralysis. But of course, the surveillance for acute flaccid paralysis is all about the identification of cases of polio. I'll explain what that means in the modern era shortly. But there are other causes of AFP and including other enteroviruses. Polio is an enterovirus, but there are other enteroviruses. Enterovirus 71 that causes is a neurotropic enterovirus that often causes a sort of a brainstem type encephalitis particularly in children in Asia, but it can cause acute flaccid paralysis. There are other viruses that can do it as well. And then Guillain-Barre syndrome, which we don't really know the cause, but it's some sort of autoimmune condition, often associated with Campylobacter, but not always. And then if you see a child with acute flaccid paralysis, always think of snake envenomation. That also causes hypotonia, similar to that. A common cause of flaccid paralysis is hypokalemia in children who've had severe diarrhea. Their potassium might be less than 2, and many of those children are very floppy and they can look like they've got acute flaccid paralysis. They have got acute flaccid paralysis. And then there's a condition that's we've talked about before that's not, I think, is probably underdiagnosed, and that's botulism. There must be quite a bit of botulism around, and that's caused by Clostridium botulinum. The From a neurophysiological point of view, it's the opposite of tetanus, where tetanus is characterized by hypertonicity and spasms and hyperreflexia, then botulism these are almost always in young infants, and they're very floppy. They often have pupillary dilatation and constipation. We talked about that before. And then there's a congenital condition called spinal muscular atrophy, an autosomal recessive condition where babies look a bit like they've got botulism, but they are young infants usually. Usually it first manifests about six to 12 months. And then there's the condition of transverse myelitis, which overlaps a bit with some of the other viral infections like enterovirus, but can also be caused by mycoplasma and other things. Now, again, we talked about the assessment of the neurological, the neurological assessment in children in the past. Just talking a bit about polio. Polio is a virus. It's an enterovirus. It formerly was widespread, and now it's much more controlled. But and most children who get even in the past, most children who got wild type polio infection didn't get poliomyelitis. They didn't get paralytic poliomyelitis. It really happens in 1 in 200. Wild type polio infections leads to paralysis. Most other children just get fever, vomiting, diarrhea, sometimes viral meningitis. When it causes paralysis, it's the neurotropic effect of the virus, and that infects the anterior horn cells of the peripheral nerves. Again, I'll explain what that is in a minute. In contrast to the much more common these days, much more common Guillain-Barre syndrome, there's no sensory nerve involvement with polio. So older children, if they have tingling or numbness or paresthesia or pain in their limbs, then it's most likely they've got Guillain-Barre syndrome, especially if it's been a symmetrical paralysis and an ascending paralysis. So ascending symmetrical paralysis with sensory nerve involvement, that's usually due to Guillain-Barre syndrome, whereas asymmetrical paralysis with no sensory nerve involvement, then think, of course, of polio. All of these are AFPs, so they need to be reported. Now, polio, the enterovirus, is spread, not surprisingly, by the fecal oral route, occasionally by contaminated water or food, but usually by fecal oral spread and relatively close contact. And then the virus, once it's in the system, multiplies in the intestine and then becomes systemic, causes fever, diarrhea, of course, and sometimes 1 in 200 is neuropathogenic. The anterior horn cells are the major neuronal cells of peripheral nerves, and they start in the spinal cord. And the anterior horn cell is the cell body of peripheral nerves, and that's where the polio virus affects. Now, when you see a child who's got a neurological problem, a weakness, if you like, any form of weakness, whether it's they're weak and stiff or weak and floppy, then it could be any part of their nervous system involved. And we've talked a bit about this before, how the manifestations of a neurological problem in the cerebral cortex look different to those in the cerebellum, look different to those in the spinal cord or the anterior horn cells or the peripheral nerves or the neuromuscular junction or the muscles. Now, I won't go over this in much detail, but the clinical features are different for each of these locations of neurological involvement. And I've shown this table before, which is you can use clinical information, the conscious level of the child, their tone, their power, their reflexes, their coordination or fine motor movement, their sensory function, to identify what level the lesion is and what the most likely diagnoses are. Again, I won't go through it in too much detail today, except to say that anything that's flaccid is likely to be at the spinal cord or lower. The spinal cord or anterior horn cells or peripheral nerves or the neuromuscular junction or the muscle. Anything above that, above the spinal cord, and even lesions involving the spinal cord are often hypertonic and there's hyperreflexia. But the polio involves the anterior horn cells. Guillain-Barre syndrome involves the peripheral nerves. It's typically the myelin sheath of the peripheral nerves that speed up the nerve conduction. That's what the autoimmune process attacks in Guillain-Barre syndrome, and polio involves the peripheral nerves. Again, I won't go through this table in so much detail. There's another talk specifically on this, on the neurological assessment of the weak child or the child who has a neurological lesion. It's worth reviewing that, I think, so that we can, when you're doing an examination, you can really understand what the clinical features are and therefore what level of the nervous system the lesion is likely to be. Now, suffice it to say, with acute flaccid paralysis, anything that is flaccid, any child that has flaccidity, acute onset of weakness or flaccidity, that's a worthy case of AFP and needs to be reported and investigated. Now, I want to talk a bit more about polio um, and and where things are in the world today. And the first thing to say is that in the last 50 years, since the oral polio vaccine has been introduced, since Sabin, it was introduced about 50 to 60 years ago. Since that time, it's been estimated there's 20 million children that have been saved from having paralysis. And so if not for the oral polio vaccine and the widespread distribution of that and the efforts to eradicate polio from the planet, then there would be millions more children, adolescents, and adults now adults who have permanent paralysis. And you probably know that in the 1950s and 60s, there were widespread polio epidemics in countries all over the world. And in fact, modern intensive care with mechanical ventilation arose from the polio outbreaks of the 1950s. So if not for polio, then mechanical ventilators of different sorts in those days wouldn't really exist. And now, fortunately, we don't need them for polio. But as I said, 20 million people have been saved from having paralysis by the global efforts to eradicate polio. And you can see here, these are reported cases. Of course, there's many these are confirmed laboratory reported cases, and especially since 1980, and then published records before that. But you can see the dramatic fall in cases of polio throughout the world in that first 20 years. But I wanted to move on to polio, one in general, and two, polio in 2025, because it's a somewhat more complex issue, and try to explain some of the technical complexities of it. Well, firstly, we know that there are three polio serotypes, 1, 2, and 3. And the oral polio vaccine, Sabin, is highly immunogenic. That is, if you get 3 doses of the oral polio vaccine, Sabin vaccine, then you have a strong immune response to polio. And that's been, as I said, central to the eradication of polio globally. And in fact, it's been so successful that 2 types of the wild type polio have been eradicated. So from the world, and that's wild type polio type 2 and type 3. It's worth remembering that 2 and 3 have been eradicated from the world. Now, type 1 wild type polio still remains endemic in a couple of countries, Afghanistan and Pakistan, for reasons that are sort of understandable, major disruptions to vaccine programs and the conflicts that have been occurring in those countries in the last decades. But it had always been that while polio, wild type polio, caused the vast majority of the paralysis, that even during the earlier decades of the polio vaccination program, very occasionally, the wild type polio 2 um, vaccine, the the strain of wild type polio 2 that's in the Sabin vaccine could occasionally not cause paralytic poliomyelitis. The strain of vaccine that's in strain of virus that's in the vaccine does not cause paralytic poliomyelitis, but if it circulates in a community where vaccine coverage is very low, especially where there are a large proportion of immunocompromised patients, either because of malnutrition or some other reason, and if it circulates where vaccine coverage is very low and where sanitation is very poor, then occasionally, estimated 1 in 17 million cases, 1 in 17 million doses of the oral polio vaccine can result in paralytic poliomyelitis. So far, far, far less than ever occurred with wild type polio, but occasionally. And what was found in the first especially 20 years of um, the major efforts to eradicate polio is that vaccine serotype 2 was the most likely to be cause vaccine-related polio. Now, remember, it's not the the vaccine virus itself. It's only if it circulates in a population and mutates to the point of being neurotropic again. So to understand polio in the modern era, you need to understand a whole lot of different vaccines. And I'll just go through them a bit and talk about what we call them. So Sabin oral polio vaccine is what we had been using anyway, for 50 years. Sabin is the trivalent vaccine, so sometimes called TOPV, oral polio vaccine, trivalent oral polio vaccine, and it's a vaccine against poliovirus 1, 2, and 3. That was the mainstay of global efforts to eradicate polio. I'll talk about this, but since 2016, we've had not trivalent OPV, but bivalent OPV. And that bivalent OPV is OPV against poliovirus 1 and 3. And the reason why WHO and all countries changed from TOPV to BOPV was because of the risk of vaccine-derived polio from circulating virus 2. If it circulates in populations of low vaccine coverage and poor sanitation and high levels of immunodeficiency, then that may become neurotropic. There is also a monovalent OPV against poliovirus 2, but it's not used now, so you can forget about that. There's a new, or what we call novel OPV2, and that's against poliovirus 2, and it's called NOPV. You'll hear more about that. That's against poliovirus 2. And in cases where there is circulating poliovirus 2 from vaccine-derived poliovirus 2, where it's circulating in a community, then NOPV has been very successful at controlling that. Then there's IPV, which is inactivated polio vaccine. You'll hear more about that, of course, and we use that regularly now, and we'll be using that more and more in the future. That is the destination vaccine is inactivated polio vaccine, which cannot cause any polio disease, any paralysis. And one vaccine I hope you will hear more about is called the hexavalent vaccine. We've got used to the triple antigen and then the pentavalent vaccine. Now there is a hexavalent vaccine that's used in many countries throughout the world, including Europe and throughout Asia, in Indonesia uses it, Australia uses it. It's called hexavalent, and it's six vaccines in one, including polio, IPV in one injection. And I think that's the future of vaccines when we get rid of vaccine-derived polio 2 circulating, then that vaccine will be very valuable. And it originally it was quite an expensive vaccine. Now it's a much cheaper vaccine, and countries many countries are using hexavalent. So I think that's what we should be pushing for now. Just to give, for those who don't remember this, there was a time in 2016 when we changed the vaccine schedule. And in 2016, the WHO that coordinates the global program for eradication of polio recognized that the type 2 component of OPV was causing some problems. It was causing a very, very small number of paralysis. But since we no longer had type 2 in the world, wild type polio type 2, it didn't make sense to keep going with that vaccine. So the OPV was switched from TOPV to BOPV, right? So just covering poliovirus 1 and 3. I mentioned before that there is um, these days, wild type polio, paralytic poliomyelitis is extremely uncommon because of the widespread vaccination globally, but rarely, relative to the huge numbers of doses of polio vaccine that's delivered, rarely there can be cases of circulating vaccine-derived poliovirus. And the one that's most common is type 2, and that's why type 2 was taken out of OPV, that instead of going from TOPV to BOPV. Right. So just remember again, type 2 was taken out of oral polio vaccine, and now we just use BOPV, which is 1 and 3. There have been um, a rise in cases of type 2, especially vaccine-derived polio vaccine virus circulating and causing some paralysis in in several countries. And the countries in which in last year were the most cases were reported were in Africa. So Ethiopia, Nigeria, Chad, Yemen, Niger, and the Democratic Republic of Congo. And you can see the number of cases, and relative to the number of um, uh, Sabin doses that are distributed every year, it's a very small number, but still a worrying number. And this all relates to, as I said, three factors. One, low vaccine coverage. Two, poor sanitation. And three, a higher proportion of immunodeficient people who have malnutrition and other causes of immunodeficiency, even chronic illness, etc. I want to talk a bit about polio vaccination in PNG, get back to PNG. And PNG was declared polio free in 2016, but the last case of wild type polio, poliomyelitis, was in 1999. So 25 years ago, over 25 years ago, was the last case of wild type paralytic poliomyelitis. And it is a great achievement that PNG was declared polio free in 2016. Uh, um, by that stage, most countries in the world had been declared wild type polio free. And then in 2016, there was a switch from the trivalent, I've mentioned this before, trivalent OPV, because PNG was wild type polio free, from trivalent oral polio vaccine to bivalent. So from 1, 2, and 3 to just 1 and 3. And as well as that, there was the addition of IPV, the trivalent inactivated polio vaccine that cannot cause vaccine-derived polio. And so to start with, we gave a booster dose of IPV at 3 months, and we know that reduces the viral shedding of the oral polio vaccine, and so therefore it's less likely to circulate in the community, less likely even in areas of low vaccine coverage to cause any problems at all. And remember that IPV is um, is trivalent, so it covers one, two, and three. If a child gets good effective coverage, effective um, doses of IPV, then even if they get polio virus, diarrhea, and fever, they won't get paralysis. It protects well against paralysis, not as well against the circulation of virus in a community. In 2021, WHO recommended the addition of a second IPV dose at 9 months. The the ultimate is going to be 3 doses of inactivated polio vaccine and none of the oral polio vaccine. But remember, if you just change to inactivated polio vaccine, you don't stop virus circulating in the community. You protect the a child from um, getting paralysis, but you won't stop it circulating in the community. So countries where there's no circulation of vaccine-derived polio virus, they have changed to just IPV. So in Australia now, children just get hexavalent, which is IPV. In many countries in the world, most countries in the world are just giving IPV, not OPV. Eventually, there'll be a complete shift to IPV, as in all other countries, in many other countries. This is some of you will remember 2018, and 2018 was a time of the first cases of um, vaccine-derived polio virus in PNG, and most of it wasn't paralysis. It was found in environmental wastewater, in sewage outlets, and it caused very few cases of paralysis, but enough to be concerning. Um, so these are the cases of acute flaccid paralysis just reported through the pediatric hospital reporting program, and there was a spike in 2018, understandably, because there was a big push to have AFP cases reported. I just wanted to say something about the 2018 outbreak. It started in May 2018, and then by June and July, there were um, starting rounds of mass polio vaccination, and there were in total 26 cases of AFP reported that were linked to this polio outbreak. And this was type 1. Remember, type 1, I said, was pretty rare. It usually causes, globally, it causes 13% of outbreaks globally. So usually it's type 2, but this was type 1. And this was well controlled by the rounds of mass polio vaccination. And the boost in enhanced surveillance, in AFP surveillance, you could see there was a spike in AFP cases that were reported, and also the introduction of environmental surveillance, which has continued to today. And um, by the end of 2018, it was a big effort, and by the end of 2018, 97% of children under 15 had been vaccinated, and in 2019, no new cases of polio were found. So that was a success, an expensive success, but it was a success. I've mentioned before why this so-called vaccine-derived polio might occur, and the incidence, 1 in 17 million doses of the the vaccine. But in fact, it's not the vaccine dose that causes it. It's the low coverage. It's the circulation of the excreted virus in the community. It's the poor sanitation and the time for genetic mutation to a neurotropic virus. Where if sanitation is poor, then it just allows this genetic change in the virus to a virulent strain because it's still a live virus. People who are immune compromised, they're more susceptible to this infection, and therefore, if you've got high proportions of children, people with immune compromise in the community, then it's more likely to spread further. And most of the outbreaks of this have been in Africa, but also more recently in Indonesia, and we've had some of that in PNG, as you've heard. Now, I talked before about NOPV. This is the novel oral polio vaccine, and NOPV is a new, relatively new vaccine that is much safer than um, TOPV, the trivalent, and it's much safer than MOPV, the monovalent. And it's called NOPV because it's safer in that it is much more stable genetically and much less likely to revert to a neurotropic virus, right? It's highly immunogenic, but it doesn't revert to a to neurovirulence, less likely to cause uh, circulating vaccine-derived polio. And this NOPV has been highly successfully used in many type 2 outbreaks. We couldn't use it in 2018 because that was a type 1 outbreak, but type 2 outbreaks, it's been highly successfully used. And and usually it requires just 2 rounds of immunization. Two rounds has got rid of the vaccine-derived circulating vaccine-derived polio. There, the current outbreak in PNG, we think, is almost certainly related to a strain of um, circulating vaccine-derived poliovirus that arose in Indonesia. I won't say too much more about that, except that Indonesia's had 3 outbreaks of this in 2024, one a bit earlier in 2022. Most of them have been with the the origin of the virus being saved in vaccine, but the last one was the NOPV vaccine. I just want to just say what the current context of the outbreak is at the moment. Firstly, there hasn't been a case of paralytic poliomyelitis, and I think this virus strain that's circulating, it has potential to become neurotropic, it has potential to become neuropathogenic and cause paralytic poliomyelitis, there hasn't been much evidence that it is. But the risk is, unless we get control of it, then it'll continue circulating in the community, fecal oral spread through the wastewater, getting contaminated again, and then undergo further genetic change that leads it to be neuropathogenic. And that's happened in some other countries. And there has been some cases of paralysis in Indonesia. So we don't want that to happen. There's lots of reasons why polio vaccination coverage has been low in PNG. I think one of them is the confusion related to the switch that occurred. It was a bit confusing to health workers to go from TOPV to BOPV and adding IPV. I think that caused some confusion. And then, of course, there was the pandemic disruption to routine vaccination programs at exactly the time that we needed to increase the level of coverage for this new vaccine schedule, and because of limited outreach services for which there's many causes. Currently, um, so far there's been, well, up until this month, there's been 9 isolate cases, and they're not cases, they're isolates. They're isolates from environmental wastewater, and they're um, circulating vaccine-derived poliovirus too. And even 9 cases is concerning. And they're not cases, they're isolates. 9 isolates is concerning because if we know that if they're circulating in the wastewater, then they're then they're likely to be involving children as well. There was um, some surveillance of healthy children done in lay, and that found 3 healthy children that had the poliovirus, the enterovirus poliovirus, but they weren't sick and are very unlikely to become sick. Remember, 1 in 200 of all children that get wild type polio infection get paralysis, 1 in 200, and it's much, much less with these circulating vaccine-derived polioviruses. But still, to leave that virus circulating in the community is not healthy, and it runs the risk of mutation to a neurotropic virus. Okay. There's been a few more. There's been a few more uh, isolates of the polio virus since then, since the last reports, even in the last month, and we know that it's a bit more widespread than just Morribee Province and Lay Town and NCD. It's more widespread than that, including up in the Highlands. Not surprisingly, it's more widespread, as again in environmental samples, not in cases. I mentioned the context of how this is happening, and you can see that OPV levels, the third dose of OPV, the coverage at the moment is about 42%. That's way too low to have a poliovirus circulating in the community. The coverage of IPV is about 60%, probably a bit lower than that. Even that is way too low. It means a high proportion of the community are unprotected from polio. Last week I talked about measles, and you can see the measles virus, measles vaccine coverage is distressingly low, 41%. So while we are thinking about polio today, don't forget what I said last week, that if we don't do something about measles vaccine coverage, then measles is all around us, including all throughout Asia, and it's only a matter of time. This is not cases of polio or surveillance cases of polio from surveillance sites. These are cases of AFP reported, and the main message here is that there are 6 provinces. They're the ones in white that are so-called silent provinces. They're currently not reporting cases of AFP, and we should all be seeing some cases of AFP, whether they're Guillain Barre syndrome or hypokalemic periodic paralysis or whatever they are. They should be reported, or viral meningitis or or true cases of enteroviral related polio. Then they should be reported. And each year, each province should identify cases of AFP and report them. It's unlikely in a province of 300,000 or 1 million people that you won't see some cases of AFP, not because of polio, but because of Guillain-Barré syndrome. So our AFP reporting is relatively low, and for some provinces it's very low. As well as that, there is low. Not only needs to be AFP reporting, but there needs to be collection of stool and sending stool for confirmation that it's not polio, that it's not enterovirus or polio. I've talked a bit about this, the role of IPV. IPV is a very important vaccine, and it's very important in the context of what we are facing at the moment, that is vaccine-derived polio, because it doesn't ever revert. It's an inactivated polio vaccine, so it doesn't ever revert to anything that's neurotropic, so it can't cause disease. The problem is that it doesn't cause the same level of intestinal immunity, and that's why the oral polio vaccines that have been used for 50, 60 years are still very relevant. Because they stimulate intestinal immunity. Um, IPV is very good at protecting children from getting paralyzed, but it won't stop the circulation. That not by itself, it won't stop the circulation in the community. That's why in the current era we need that NOPV, the rounds of supplemental immunisation activities with NOPV and later IPV. The second round will have IPV. Right. And finally, as I said, I hope the destination here in the next 5 or 10 years at least um, is going to be the hexavalent vaccine because it is being used in many countries very successfully to prevent 6 diseases in one vaccine. So it's got the triple antigen, diphtheria, tetanus, pertussis, and hepatitis B, and IPV, uh, polio vaccine, and Haemophilus influenzae type B. So it's similar to pentavalent, but it's got extra vaccines and including IPV. It's a single injection. We need to change the schedule a bit, not 1, 2, and 3 months. It's probably got to be 2, 4, and 6 months, or the first dose of hexavalent can't be given before 6 weeks. So most countries have a 2, 4, 6 month schedule. Very safe schedule. Licensed by WHO 20 years ago. So it's not a new vaccine now. It's been licensed for 20 years and used widely in Europe, in Australia, in USA, and even in countries throughout Asia because they've realized it's so much better just to give one injection for protection. Of course, we'd still need to give measles vaccine, MR, measles vaccine 1 and 2, measles rubella vaccine, and we'd need to still give a birth dose of hepatitis B, and we'd need to give BCG. But it would simplify the EPI system, and I think that in the last decade we've actually had the EPI system has become more complicated rather than simple. And I think the overcomplexity of the EPI system doesn't help for adherence and good vaccination coverage. And we'd still need to give pneumococcal vaccine. That's not included in hexavalent. So there would still need to be, a number of vaccines, but it still would simplify the immunization program a whole lot. But before we do that, we really need to get rid of the circulating polio virus that exists at the moment. Right, well, that's all I wanted to say. And in some ways, I wanted to be somewhat of a sort of clinical update on AFP, but also to try to explain some of this complexity surrounding polio in the 2025 and some of the, I think, quite confusing complexity around the different vaccines that are available. I'm going to stop the recording now, and I'm happy to then answer any questions that you might have.